meeting to order, and we won't do any action items until we have a quorum, I guess. So, introductions.
Terry Jeffries, Mason County Commission.
And I am Peggy Van Busker from Hospital District 2.
Kathy McDowell, City Commission.
Lydia Buhite, Mason County Public Health.
Dave Wyndham, Director, Mason County Community Services.
And we have several guests. You want to introduce yourself?
Todd Barker, Mason County Housing and Mental Health Program.
Okay.
I'm Laura Tony, Thurston Mason, DHO Care Manager.
And I'm Marilyn Vogler, Shelton Citizen.
Yay.
I also want to introduce Jennifer and Melissa, I'm sorry. Your last name?
Drury.
Melissa Drury is our new clerk of the board. And so I assume that she'll be clerking once she's learned the ropes.
Yeah, she's been filling her in. I can hear it back there.
Okay. And I just wanted to also make a point of, if it's okay.
Sure.
I wanted Ms. Tony to be able to talk a little bit about your services and what you'll be doing in Mason County when it's appropriate on the agenda. So I'll defer to you. I hope to do it in with the Mason Matters update, but I don't see the Jeannie's
I
here.
don't see Jeannie either, but maybe we'll do that instead of Mason
That
Matters
would work.
update.
Is that okay?
Mm-hmm.
Yeah. So, since we can't really approve the minutes for the agenda, are you going to do Diane's report?
Right.
So maybe I'll let you do that.
Okay, so in your packets, you received the packet from Dr. Yu about the opioid update. Actually, in your package, you had a number of
Yes.
items. So the one from John Weisman is background information on the Secretary of Health's view of where public health is going. I thought he had a very good speech this last time at the Washington State Public Health Association. So we got a transcript of it, and I included just as background.
Sure wish I had the PowerPoint. He kept referring to the PowerPoint.
Well, actually, part of his PowerPoint is in my PowerPoint.
Good.
Because he and I turned around and we presented together 2 weeks later.
Okay.
So a lot of what is in his is in this. So so you can set the piece from John Weisman's side. It's background reading. The piece from Dr. Yu, she had a very detailed report talking about the opioid response. She's gone back in time and talked about the background, current practice, what's going on in Mason County. I particularly was interested in the piece about the Shelton Police Department is using Naloxone.
Yay, Shelton, please.
And they've actually used it already and had a rescue.
I think a couple now.
Yeah, a couple times. So that's, I think that's real progress right there. We have in the past couple of weeks, we've kicked around talking about what is the one that makes you ill when it's not Naloxone, it's you use opioids after taking this. It's not methadone, it's
Suboxone?
Suboxone.
Yeah.
We don't currently have a provider that does
We're
that.
working on it, though.
We're working on it. It was something we did in Northeast Tri-County at the Stevens County Jail. We had a doctor who was very involved with that, who did case management for anybody who was there 30 days or longer, and did Naloxone in conjunction with therapy and counseling. Seemed to have pretty good results. So they weren't going out the door needing that first fix. So, yeah, so she doesn't have any of the Suboxone as well. So it's a detailed report.
It was very good.
I know she wants to come in and talk about this. This is her passion.
Yeah. So in January,
So in January, you'll probably be seeing Dr. Yu. So this is an issue that's become more important as the price of heroin has come down in relationship to other opioids, that people are misusing. So the high is longer and the cost is less. So heroin is really seeing an increase.
She refers to a grant frequently. Does anybody know what that grant is?
She's probably referring to the grant, the DOH grant, where we're having, we're gonna house a nurse in our office, a part-time nurse. She's gonna be going out and working, doing follow-up case management with anybody who has had naloxone use or has been reported. It's the CDC has sent down some money, and we were one of the 2 counties in the state chosen to work on this. And so, I'm not sure, because I've been gone for a few weeks with family illnesses. I know we were waiting, there was a bump in the road with DOH, and they were solving that, so I haven't heard the update on what's happening, but we were supposed to be ready for her, or him, I'm not sure, it's a male or female, at any time to come in and work with us. So they would be working in conjunction with our staff, as well as working mostly out in the community.
Okay,
So I think that's the grant she's referring to in there.
okay, thank you.
And it's not our grant, we will get some service money for some of the supplies and things that we're supporting it, but they're actually, DOH got the grant and is using it to pay for this year's.
So it will be a state employee housed
Yes,
hearing?
yeah, correct,
Okay.
correct.
We get to do the recruiting.
We pay more. They get more.
Before you go into the foundational public health, maybe we'll have you speak.
Sure.
Okay.
So again, my name is Laura.
Why don't you
Why
come to
don't
the
you come
table?
up here?
Come on up.
Yep.
Sit or?
Front and center, yes.
Maybe I should.
So as I said, I'm a care manager for Thurston Mason DHO. It's a new position where I primarily represent Mason County. So historically, the care managers have been assigned to agencies or certain types of programs, but I specifically want to represent Mason County. So that includes substance use disorder and mental health treatment. So some of the programs that we are helping develop right now is DHR, Catholic Community Services, Community Youth Services, Family Education and Support Services, Northwest Resources, and then we're participating in the Therapeutic Court program here, as well as True North ESD 113 services. So right now I'm just getting up and running and getting to know all the programs in the county, so an information gathering phase, so not a lot of action yet, but hope to get there after we kind of figure out what's going on around here and what's needed, what's missing, what's duplicate, things like that. I'm happy to be here. Yeah.
Get
So,
you-
would your role, can you explain a little bit more what you named literally all the agencies in our community that are working in those services.
Mhm.
So what would your role be to see how you can help support them?
So we contract with those agencies,
Mhm.
and we authorize the care that each client gets.
Okay.
And so we're very involved in the management of the client's care, making sure it's the right level, the right type, the right length, things like that. Make sure the programs are in compliance with those contracts and the clients are getting the services that they're needing. We can also develop new programs. So if there's a hole that is found in the community, the idea can be proposed and put up to start a new program. And so I'd be involved in helping getting that started.
Any other questions?
And
Okay.
just to share that Laura indicated that she would be attending these opioid response Suboxone service. I don't know what they call that community group, but she'd be representing the DHO there.
I have not. So Jason Dean Mortensen, he's a chemical dependency professional, that's a care manager, so he's been going to those. And we haven't transitioned yet, but that's definitely the plan.
Okay. So I guess we'll move on to you, Brandon.
Okay, so before I really start into mine, Lydia has been out with some family issues and has her report to hand out. She wasn't able to get into the briefing packet, so we'll have that go around. Anything you wanted to add or bring
So
forward?
basically, just excited to say that I have full staff as of now. I'm very excited after a year to have full staffing and So I've got some updates on the staffing, what's going on there. Our maternal child health programs, 2 of our nurses, or actually all 3 of our nurses were invited into a specialized infant mental health training put on that they're going to be involved in. We were one of the organizations that the whole state picked, so we're kind of excited one of the counties picked that has Nurse Come On partnership. Housing has some information there of what Todd's jumped in and been doing since he's only been here not even a month yet, but doing a great job in connecting with all of our housing agencies and getting the PIT, the point in time count for the homeless count that happens on January 27th. So there's a little information in there about that, and you'll be hearing more about that. And then the community health improvement talks a little bit about kind of what follow-up's been going on. Dr. Hughes report's much more detailed, but this is more of a summary of some of the other groups, including the prevention group that has joined with the Substance Abuse Prevention Coalition that had been going on for some time already in this community, but they've now joined the group that was formulated at the opioid forum and doing some good work there. They've moved to where their meeting is. It's going to be up at the high school because they want more youth involved, and the meeting time was preventing youth from being able to be involved in the location. So that was something that helped that. So that's just a little bit about kind of what's happening in my division right now. And then,
Yeah, let's hold off on that.
okay,
So-
so that's basically, I'm just happy to have staff. My new nurse started, she was going to be here, but she had a doctor's appointment this afternoon. Vicky Marquina. They're both, Todd and Vicky, are local Mason County residents. Woohoo!
Yay!
And so she's been working in Kitsap County for approximately 10 years as a nurse, and she's new to public health, but she jumped in, and Diane Crabtree, who was my wonderful retired nurse that came back after 6 years being retired, she came back and held the fort for a couple, 2.5 months to help me out, and that was really wonderful. She helped do some of the training for Vicky, and Vicky's doing great. She's only been here the 2 weeks that I've been off. I got to see her for 4 hours before I had to take off, but she's doing a great job. So excited that we have that, and hopefully we can get back on task, and I can get back to my job. Looking forward to that too.
Okay.
Okay, so jumping right into the next piece, foundational public health, you've heard me talk about before. 2 weeks ago, the Secretary of Health, the Director of Seattle King County Public Health, and I did this presentation for the county commissioners at Wasac. So this is a recap of what we did at Wasac, and it follows my staff report. So the staff report's in the packet. This follows it with a little more of a it's a presentation. So we'll go ahead and jump into that. All right, so we're talking about how we got to where we are, what we asked, what it means for Mason County, and then the kickoff of this whole Public Health is Essential campaign. So the road to today. So back in 2000, motor vehicle excise tax was repealed. Much of that went to public health. That was kind of the heyday of public health funding. Staffing was back then more than twice what it is now. It was good times because not only did we have that, we also had the tobacco settlement money came in about the same time. So public health was kind of in green pastures back then. 2001, property tax was capped, and counties know what that means. Since then, inflation has been the issue that's eaten up. Every time we have 1%, you have a 3 or 4% inflation that chews that right up. Since then, federal government categorical changes have happened, and you can use tobacco as an example. So the tobacco funds from the feds have dried up because they got settlement money. And Washington essentially spent all of their tobacco funds in advance, and is in the process, when they get settlement money in, it goes to pay that debt. So they spend a lot of money up front, and then they're repaying them. In 2009, the other priorities, in 2009, the state legislature swept the tobacco funds from the tobacco tax, which was $555 million a year. It's the state's 5th largest and most stable source of funding, tobacco tax, into the general fund. So the state funding that we got from Department of Health, through Department of Health, Treasury, Department of Health, us, went away in 2009. So as of 2009, much of what went to tobacco, especially chronic disease, diabetes, obesity, work, is gone. That money's gone. In 2011, we started a project, and I was part of the pilot on that, where we took 9 health jurisdictions and we looked at what are we actually spending. We looked at our BARS reporting system. What are we spending in these programs? And then extrapolate what would it cost us to do them correctly. Now, I'm talking just the foundational pieces. So if you took everything public health does, and you look at just a subset of what we have to do, you know, what does that cost us? What should it cost us to do it correctly? And that's where the $100 million came from. Once we extrapolated that across 35 health jurisdictions, 39 counties, the difference between what we're doing and what we need is about $100 million per year. Well, legislature's just not going to go there. So down the road we go with other solutions. This gives you an example of the tobacco funding. So you see the heydays were up until about 2008, going into 2009, and of course with the economic recession that dropped down and the sweep from the legislature into the general fund. There was a note on the Department of Revenue saying they're very frank, saying that if people actually quit smoking, it's a reduction in revenues to the state. So
It's
this,
still okay with me.
What's that?
I still want them to quit smoking.
yeah. So I mean, the revenue system has an investment in people smoking, and it's what it is. If you look at prevention and outbreak response, it should be balanced. You know, we should have enough resources to deal with the outbreaks that we anticipate. You can't anticipate everything. You get something like Zika, or you get any number of the Ebola, for example. No funding, and it's just something that came at us out of nowhere. But ideally, this is the response. And last year, Chipotle, closed in dozens of locations. Monroe School District closed after 2 students were hospitalized with E. coli. In Newport, we closed the middle school when over half the teachers and 70% of the kids were out with norovirus. And it took us, this was like the last week of school, we had to close the school and then sanitize the school from one end of the school to the other. And just send the kids home and we'll see you next year. And it took weeks to close that. And for example, we were down to 2 people in the health district at that point that worked with communicable disease. So we had to pull people from other health jurisdictions, other parts of that health jurisdiction to manage that. So the funding is just not there. To give you an idea, if you're dealing with a pertussis outbreak and you spend $40,000 dealing with pertussis outbreak on direct service, and that's tracking down all the cases that may have been in contact, that's getting the antibiotics, getting them out to those for prophylactic purposes. $40,000 is easy to spend on just a few cases. You figure about $2,500 per case identified. Doesn't take long, but the real cost to the agency is about $80,000 because the nurses and staff that are dealing with the outbreak are not charging to the programs to keep them employed in the first place. So nurse family partnership or whatever. So they're dealing with their response that they're supposed to have, but they're not billing for their time in a way that's reimbursed. Outbreak response, not reimbursed. There's no source of funding. So this is what the reality actually looks like. We have a tiny little bit of prevention, and we're dealing with a lot of disease load. Especially if you look at the diseases that are our biggest mortality: smoking, disease-related stuff, and diabetes, obesity-related diseases. Those 2 things together account for most of what we see come through in our death certificates every month.
How about the alcoholism rate?
That doesn't show up as much in our death certificates as the other 2. Cancer related to smoking and cancers and other illness related to obesity, diabetes, whether it's COPD, heart disease, those things account for the vast majority. I look at all the death certificates every month, look at those sorts of things, and so does Dr. Yu. Trying to look at the trends, see if anything leaps out at us. And that's what leaps out at me is it's carcinomas and chronic disease. So we look at the whole system. We said we can't deal with the whole system. The elephant's too big. So we said let's look at the core piece, and as we had defined that earlier, those things that we have to do. And you really can categorize those. My shopping cart story is if it's something you accidentally can bump into that affects your health, that's foundational. That's food, air, communicable disease, those sorts of things. That's foundational public health. So foundational in Washington, one of the things we used as our goal was ensuring that all citizens, all residents of the state, not citizens, all residents of the state can depend on a core set of services no matter where they're at. If they're in Garfield County, population 2,500, or if they're in King County, they should be able to count on clean food, clean air, and water, and relatively free from communicable disease. So if you look at those pieces that we found to be the core programs, vital records were mandated by law to do vital records. Communicable disease control, chronic disease, maternal child health is another one that we're mandated by law to do. Access to clinical care has always been a foundational piece of public health. We don't have to do clinical care, but part of our role is to make sure that the access is out there. Environmental public health, we are required to do that by law. Capabilities are all those other pieces that allow us to do the core programs, assessment, epidemiology, policy development. That's what the board right here is doing. It's policy development. Communications, emergency response planning, community partnership, and then all those business competencies you have to have just keep the doors open. So each health jurisdiction should have those as well. So we looked at public health as a shared responsibility. One of the things that guided us through this process was that some counties give a lot of money in support of public health. Some counties give almost no money in support of public health. There's a couple counties I know of, one in particular that supports public health to the tune of around $150,000 a year and takes back $125,000 in rent. So it's an interesting, and no two health jurisdictions are the same. When you look at how they're funded and what proportion of funding comes from where, it's different everywhere. So we looked at the core programs, capabilities, and how do you meet the local needs by those two things, and what do you focus on first. So we looked at what's going to get us through. We have a number of health jurisdictions that are in risk of financial failure. And it's not necessarily just the small ones. We have some big health jurisdictions that are facing some major layoffs in the coming year. So we said, what is a gap filler while we get into the rest of this process? How do you modernize the system but keep the system going until you get there? So what we're looking at is an infusion of funds in a specific way. Knowing that the legislature has a hard time just give us money and we'll do great things with it. It doesn't fly very well. So, give us money and we'll do these specific things with it. These are the kinds of things. And if you look at our mortality rates, these just jump to the very top. Chronic disease, communicable disease. So here's the state budget request. This is on a biennium basis. We're looking for $50 million for local health jurisdictions. That would come directly to local public health. It would come through Department of Health with no takeouts. So there'd be no overheads. That was a very difficult negotiation over the last 6 months. Department of Health would get $6 million. Primarily would be going towards services like the state lab. State lab in Spokane closed, so we're down to one state lab. So we have no redundancy, and they really need to get that other lab, I think, opened up
Where's
in case
the
you
other
have a.
one?
What's that?
Where's the other one?
No, shoreline.
Shoreline, yeah. So you really need an east side and a west side. So in case you have a major earthquake event or something, you have a lab on the other side that can pick up the slack. And then $4 million in modernization. And the modernization that they're talking about there is a shared services model. So maybe you don't need and you don't need an epidemiologist in every health jurisdiction, but can we pay for and share an epidemiologist in a way that's cost effective across multiple jurisdictions? In some cases, they're going to share environmental health services across jurisdictions. In a contractual way, it can be in a handshake agreement, however they do it. But we're trying to do that in a thoughtful way that we can explain to the legislature. This is what we're going to do with this money in order to spread services in a way that makes sense. So what does it mean for us? We went through a long process of allocation formulas, which was very contentious and still is. But for Mason County, it's going to look to be around $209,000 to possibly as much as $249,000 a year. Targeting things like opioids and heroin, which is a passion we have here, STD surveillance, other communicable disease, Hep B, other infections, and then healthcare facilities. Other things we had talked about was, some of us counties, clean water is a big issue. How do we, ensure we have clean water? So yes, there's flexibility to spend the money towards those things as well. And it would also allow us to spend money in the infrastructure that supports these programs.
Is there any way that you can protect this allocation? Should we get it from non-supplant language?
We're working on that because that's been a big contention. So we get this money. Some counties I've talked to said, great, we are going to buy cop cars and more deputies with the money we're currently giving public health. So then there's no gain. So that is an issue, and it's been discussed at length.
Because this is just for the core, that doesn't mean the rest runs.
Right. So if you look at those other things, so in my last jurisdiction, I did family planning and I did WIC. So those are considered additional important services, AIS. And those services, we felt if they're important to the community needs to support them. So everybody has access to the core, but those particular programs that are community specific need to be community sponsored. It just made sense. So the plan, the campaign we came out with is Public Health is Essential. And now we get to watch this short little video.
Across Washington rely on essential public health services, often without even knowing it. But even though our state's population has grown, funding for public health has decreased. As new and complex threats emerge, we're risking the health and safety of our communities. We're risking food and water contamination. We're risking the spread of epidemics that could otherwise be tracked and controlled. Responding efficiently to public health concerns saves public dollars and protects our economy. Other states are rising to the challenge, and it's time we do the same. Washington must rebuild our essential public health services so we can monitor, respond to, and prevent public health emergencies. We must keep our children in every corner of the state safe and healthy. To learn more, visit www.publichealthIsessential.org.
Very to the point.
Short and sweet. On the slide that showed the difference between Washington, Idaho, and Wyoming, one thing to keep in mind is that Wyoming is a centralized system. But the state is in charge of public health. It's not a local responsibility. So there are some differences in how public health is delivered that changes the way the state's funded. So here in Washington, it's a partnership between both the counties and the state and the feds. So our money comes to us from a variety of places. We have grants, we have State funding, we have some federal funding, which is grants, primarily passed through the state, and then fee for service
So that is $30.08 per what?
per capita.
Okay.
I did a study on this during my master's program. Around $43.50 or so comes to the state of Washington each year per capita for public health, and that's from HRSA. So what gets out to the field is about $3.48 comes out to local health jurisdictions. So it gets spread across a lot of avenues when it comes to the state. So we have a whole social media campaign going out about public health is essential. We'll be talking with legislators shortly after the first of the year. We have some materials, and I have some materials for you to take with you, to hang up, or whatever you want to do with them. So Lydia will pass those around. It talks about this, how do we prevent epidemics, track disease, and respond to disease. Which brings us to the resolution, which we don't have a form for.
Yes. So hopefully we will next time. Maybe you better get on that to make sure we have quorums.
Rather than sending it over to something.
Audience. So we can't really even pass our meeting schedule because we don't have a quorum.
I'm sorry, folks, I don't know what to say.
But maybe next month, since we have a new commissioner, maybe we can get all this taken care of right away.
Mhm. So talk to us about how this resolution would then be,
So WSOFO is going to compile resolutions passed by local boards of health
okay?
and use that. We're hiring a lobbyist through WSOFO. In fact, I'm on the interview panel this week. And it's just more ammunition that we can use to take to the legislature to ask for this $25 million or $50 million per biennium ask. To plug the holes while we get the system modernization lined out and ready to roll. So it's going to look, public health will look different in 2 to 5 years. If this goes through, you're looking at state supporting a lot of the foundational pieces. So what does that mean for locals? I'm not sure. Does it mean state funding for counties comes from someplace else? I'm not sure.
And I know that the State Department of Health have been working on the Foundation of Public Health Services.
That wasn't the state. That was a cooperative between, the state had a piece of it, but it was, we had county commissioners, we had the unions, the Nurses Association, local public health. It was a wide variety of people that worked for about a year and a half to put that piece together. And then we had a technical committee, which I was also part of, that was running all the numbers and feeding that to the policy committee as the policy came up with this plan. And now it's kind of been put to WSOFO and DOH to sell this to the legislature.
So will this be the part of the budget request from the DOH to the
Yes,
legislature?
so on the 16th and the 19th, I have time set aside, depending on when Governor Inslee's budget request is published, to go through that with DOH to see, this is in DOH's request to the governor.
Okay, so it is in there?
It is in there.
Okay.
And we've been working with Office of Financial Management for months now, answering their questions, because they had, once we put this request to them, they had a host of questions. Like, what are you doing with your tobacco money? And we had to say, we don't get tobacco money, not anymore. We used to, because there's just a misunderstanding at the state on how we're funded. They don't know how we're funded.
Okay.
So it's taken a lot of back and forth between us, the governor's office, and Office of Financial Management, and the Senate. The Senate has gotten kind of involved in this as well. About how do you ask for this, and what is the buy? I mean, what does that $25 million buy?
So when is this when were you going to put this?
I want it as soon as possible.
Yeah, that's what I'm afraid of. So, what's your opinion of this? I mean, we can't really, we don't have a quorum.
Right, so if it's to come from the Board of Health, I mean, we have a couple different things. I mean, do you want it to come from the Board of Health, or would you, we don't have a quorum enough to move to recommend that this county commission adopt it, so.
Should we hold a special meeting? I mean, when do you need this? Like yesterday, probably.
Right, we're trying to put them together. I'm kind of working with the small rules to get this together. And everybody's having the same problem. Some people aren't meeting until next year.
Okay,
And we're not meeting till the end of January,
right.
The session begins the middle of January.
Right.
so that's what I'm worried about.
I think we
We're not
would need
meeting
to
in
do a special
December?
meeting.
Yeah, I'm thinking that we should have a special meeting in December.
We were not gonna have one in December.
We don't normally.
That's right, it's in, oh, okay, skip a month, yeah, okay.
Right.
But when would that be, I guess, is what,
I think that's a function of finding out availability to
Okay.
ensure a quorum.
okay. So
So,
should we
could I
put
look
that
to the
on-
clerk to maybe
to
do
set up a special meeting?
based on availability?
Yeah, we can hold board.
Okay.
Thank you. Thank you. There were 2 resolutions, weren't there?
Yeah,
Right, the other one was to set the
Oh, the
meeting dates for
meeting
January,
dates.
or for
So-
2017.
which we could do at that same special meeting.
could.
Just keep in mind, if you call a special meeting, you can only act on whatever you put on that agenda.
Right,
So
so we
make
would
sure-
just put the 2 items on there,
Okay.
and that would be it.
And
And do we
potentially
have to
would need-
advertise it?
Yes, it'll
Yes.
be a notice, it'll be a typical notice for a
Okay,
special meeting of the Board of Health.
okay.
It's a 24-hour notification, so.
And then I would kind of recommend that in that, the content of that meeting, that your presentation be repeated if we're all okay seeing it again, just for the benefit
Yeah,
of
that would be-
the folks
Okay.
that are.
It's
Yeah, we
not
can run
that
through-
long.
It's not that long, we can run through it real quick.
Right.
Yeah, I think that that's a good idea because I really think we need that to go with you in January.
Are you convinced that the issues that the Mason County faces are unique enough to Mason County? I mean, what I see being highlighted in this: heroin, opioid addiction, youth suicides, STDs. Are those the four areas of concern that could be directly related to the reduction in funding, do you think? In your experience too, Lydia and Debbie, I mean, you have a lot of years of experience here.
I think so. I think when we lost the funding for tobacco especially, so the population's getting away from us. You know, we're not seeing decreases in use of tobacco anymore. It's leveled off, if not starting to come back up. And now throw vaping into it with its unknown, and marijuana. So I think it addresses that. I wanted to address a couple specifics and then the generalities of diabetes, obesity as well.
Okay.
And then the STDs, we have been strapped with money, we need to get out there and there needs to be education, we're never gonna bring them down, they're just climbing.
They are.
Yeah.
And in the water quality portion, there's still some protection we need to do to prevent against illness with consumption of the shellfish from certain areas.
Okay, so, I guess we haven't gone over your part, Debbie.
Well, actually, we're moving on to the nursing contracts updates.
Oh, yes.
And that's, Lydia, that's your,
I guess I don't have the right thing, because
No.
it's not on here.
Yeah,
well,
it's
I-
on here.
It's not on mine.
Foundational, and there it says nursing
Nursing
contract
97.
update.
Yeah, mine only says funding updates.
Oh, okay.
It's over there on the podium, but that's fine. I just didn't know, I was just waiting. So, Dave asked me, this is kind of this little piece of paper, and I'm going to give it to everybody, because this little paper just kind of tells you a little bit about our maternal child health programs right now, so that you have that background understanding. We have the Nurse Family Partnership Program, the Children with Special Health Care Needs. program, early intervention program, which is a CPS connected program that we work with CPS, and then the Work First, which is basically Work First, which is part of TANF with DSHS. If a parent comes to a certain point and can't go back to work because they have certain roles, then they need to be checked out through a nursing or a service that they can demonstrate that for some reason their child will not allow them to be able to go back because they have some special needs. So we've done that contract for a number of years. It's it's changed over the years, and now it's a fee-for-service contract where we wait for referrals from DSHS to send them to us, and then we respond. We're only paid if we can find the client. Sometimes that's not so easy, and so we don't get paid for our efforts. There's also, it's a certain fee, so if you have to go see that person 6 times versus 2 times to determine whether or not this parent really has the ability to go work outside of the home, we still get paid just a certain amount. Because I'm down on my staffing, one of my nurses, and I forgot to put that in the newsletter, but one of my nurses is going on to get her her nurse practitioner license, and so she's agreed to stay with us, but she's reduced her hours 10 hours a week so that she can continue her education. And so we're down a little bit there on our nursing, plus we're kind of catching up from a year of having one of my nurses be off. It's hard for them to, as you can see, their FTEs are replaced there. We have 2.7 now FTEs of nurses. This is not including my communicable disease nurse, my brand new one. She's not part of maternal child health, so that's separate. She's got her own other jobs to do. But this is just the maternal child health. So what I want to do is I actually want to drop this contract. This contract says in it, you've got the second sheet that talks about the contracts, it's $6,000 for 6 months, so that would be $12,000. That's kind of a nebulous number because we really have never used that amount. In 2015, they sent us enough referrals and we were paid $2,600. It doesn't sound like a lot, but it's and the money's not, but what I'm trying to point out is an added contract that pulls my nurses away from their 3 main programs to go hunt people down and try to do this, to me, is not worth it.
And which one is this one for?
This is the Work First program, number 4.
Okay.
So I'd kind of like to just drop this contract and let DSHS find some other source to do it. It's just pulling them in different directions. In November, October, November, they got 6 referrals because a new person came in and they weren't even accurate, good referrals. And so it was just pulling them their hair out. And I'd rather just not resume this contract. And so they wanted me to share that information.
I wanted to bring it to the board because it's not just a monetary thing, it's a policy thing. And the Board of Health decides policy, and then the monetary things trickle down. So we wanted to bring it to the board.
It doesn't seem like the best use of our time anymore since they've changed how they fund, and we just wait for referrals, and then they have to be acted on within a certain period of time, so it pulls the nurses from some of the other things they're doing, where there's a lot more funding that's supporting their work. So I just kind of wanted to remove some of the added burden on them at this point. I didn't feel this one was really one that a DSHS can find another nurse to be able to do it. They might even contract with our former retired nurse, which many of our little
And
contracts like this went
basically,
to.
they have other options, is what you're saying.
Oh, they always have other options.
So-
There's lots of nurses in the community.
Yeah.
Yeah, I just feel like this one's kind of starting, I watched it happen in the fall. It just started pulling the nurses. Because sometimes they can be very difficult cases, and one of them in particular was more in the mental health, which really wasn't an appropriate referral. My nurses are not mental health specialists. They have a lot of training, but they can't determine if a child is in such a situation that the parent can't go to work. So we tried to say that to them. So we weren't paying for it, but it took a lot of time.
Yeah.
So, yeah, I just think it's a better.
And this makes them eligible for unemployment?
No, this is for their TANF. See, at a certain point, they have to return to work after having a child. And if they are not able to, there has to be some demonstration of why they can't. And so they utilize this Work First evaluation done by nurses to determine whether or not, well, often if it's a premature infant, if it's an infant with special child, children with special health care needs, that's a little different. The nurse can go in there, evaluate, yes, this mother needs to be here, this child can't go to a normal daycare or something like that.
So is this just any mothers that have babies?
This is mothers that are on TANF.
Okay, I got that.
Yeah.
And TANF is?
TANF is the support for parents, single parents or parents, yeah, that need financial support.
Used
So
to be
they,
called welfare.
yeah, it used to be called
Used to be
welfare.
called welfare.
Temporary aid to needy families is what TANF stands for.
Okay.
Yeah.
When
Now it's
that was the
5
Bush
years
administration,
long
wasn't
now.
it?
Yeah, now it's only 5 years, so after 5 years, they have to make some plans. But after so many months of having a child, they have to return to work. They can't just stay home with a new child. So this is all part of that process, the DSHS.
Right, I get it now.
Yeah. So we were one of the, when we had plenty of money, lots of staff, it was an easy thing to fit in, but it's getting harder and harder to do this contract, so, got it.
And it really fits into the discussion of what's for public health,
Mhm.
what's foundational to what we do. And if there are other resources out there, then maybe we need to push some of these things out to those other resources.
And one of the reasons also that contracts like this were picked up was to save your nursing staff from being let go for the core services, communicable diseases. As it seems to me that my education of 4 years of doing the budgets here at the county, that when things got tough, more contracts were picked up that would, the contract work that was the grant funded would help sustain the core nursing.
Well, because the
Staff.
county used to give us $400,000 more dollars. So
Right.
yeah, now we're basically down to grants to support our staff. And my staff has, as you can see, the Nurse Family Partnership has 3 grants cobbled together there just to support 2 nurses, 2.5 nurses. So all of our monies is small little amounts, plus these grants have gone down over the years. They haven't kept up with inflation, they haven't kept up with benefits. So the reality is, that's one thing about grants, is they don't keep up with the cost of things. So you end up having to add more grants. This particular grant we've had for a very, very long time, many, many, many years. It's changed over the years. But we've had the 2, 3, and 4 probably for the 17 years I've been here.
Do you have to reapply every year for those?
Yeah, they're always renewed. I mean, yeah.
You have to apply.
Not
We don't
necessarily
apply.
every year.
Yeah.
Sometimes they're in the biennium.
Yeah, this particular one.
Consolidated contract.
Yeah. This particular one, as you'll see, they only set it up for 6 months at a time, which I think is kind of interesting. But they're different.
Looking at calendars, I just wanted to check with the board members that are here. Looking at the commissioners' calendars, the options could be next Tuesday afternoon, the 6th, or next Wednesday morning, the 7th at 9, or the following Wednesday, the 14th at 9. Do you know if there's any conflicts with your calendar?
Did you say next Tuesday morning?
Tuesday afternoon,
Tuesday afternoon.
like at 3:30, I was thinking, or the 7th or the 14th at 9 a.m.
7th or the 14th would work for me at 9.
Okay,
And also me.
okay. So I'm gonna pose those 2 Wednesdays to the rest of the group.
So does the board agree that we can,
Well,
Use
we
this one.
agreed that we can't really make any
Well,
decisions, yes.
but you can, but I can get a
Yes.
consensus from
Yes,
this.
I think that you need to put your efforts where it's most needed.
Okay, so drinking water, we're just going to touch on that just very, very briefly. In the last month, a decision came out of the state Supreme Court that affects drinking water in the state, the Hearst decision. And it talks about, so part of public health is water adequacy in wells. This addresses drinking wells from a legal availability of water, not just water availability and potability. So we haven't got our heads wrapped around it. It's really more of going to be of a planning issue for us because we're not doing water adequacy in the same way that other counties are. So I just wanted to let you know that the issue is out there, we're working on it, and we're going to be we're tackling it very hard from the planning side of the house. There's a lot of ramifications, there's a lot of meetings going on. In fact, there's a meeting Thursday. There's
Wasac?
No, well, there's Wasac meeting in the morning, but there's a
Joint,
A
the House
joint-
Local Government and Senate Agriculture.
right in the afternoon, like at 1:30.
Mhm.
So I've gotten a couple calls from realtors, so I just wanted to bring it to the board to let the board know that yes, it's out there, it's an issue, we're working on it. So I can answer any questions you might have. Okay, seeing none.
I
Nope.
did have a quick
Okay.
question. I have been having a heck of a time finding, I think somebody had sent me the information that said which basins are closed for new water withdrawals. Do you happen to know which ones those are?
Not off the top of my head, but yes, they're in law, they're in a WAC, and it's, the Goldsboro, Kennedy Creek area, Johns Prairie,
So Johns Creek,
Right.
okay.
and that might be it.
I'd have to look.
Yeah, I
We
can
have
get
3
that
wires,
over to
but
you.
the one of them is a shared. And see, that's one of the problems in dealing with this is is the county, if we come up with a solution and we have a shared wire with another county, and so those are water, use areas.
Okay.
You might have 2 different regulations pertaining to the same watershed.
Somebody had emailed me the information and maybe some maps, but I can't for the life of me find that
I
email.
think you emailed me the WAC and then Barb and I sent out, I think.
I can't find it in my, is there any way? I
We'll
can
resend it.
that?
We'll
Thank
put
you.
together a resend.
I appreciate that.
And I have one more thing besides the water. I was ready to jump in wherever, but of course Dave covered it just very nicely. In the keeping with public health is essential, on my drive in this morning, I had the radio turned on, and they were talking about 3 people dead and 5 sickened after Thanksgiving dinner in California. So I went online and pulled the article, and it was in Antioch, California. It was a community Thanksgiving dinner put on by a church event, and the people who were stricken also lived together at the same care facility. Right now, the health department there is saying that the public at large is not in any danger. They're trying to figure out what the agent was, where it came from. But it seems to be just these 8 people. There aren't other people at the health care facility. There aren't other people that ate the dinner. But once again, that's why we have people trained up and on standby when these things happen. Mason County has had a couple of really big foodborne illness outbreaks over the years. So far, we're pretty lucky. Like I put in my report for the last 2 months, the only call we had after the Oyster Fest event was somebody who had a urinary tract infection and thought they were food poisoned. So we had another teachable moment there too. But just one more reason why public health is essential, and we're there. We're like law enforcement and fire in the fact that we're not always out there putting out fires or arresting bad guys, but we've got to be ready to follow up on foodborne illnesses that even cause deaths.
Mhm. So
I'll get off my soapbox now.
So, in other business, I had just a few very fast things. I see we're already an hour here. I have the Wasalfa legislative agenda. We've been working on this for several months. We presented this to Wasac. I got some feedback from Wasac, and we made some changes to it the next day. So, the big issue is foundational public health services. The shared services modernization. The second largest thing is the governor's executive order on lead. So we'll be working on lead as well. Just for background, we've not had a problem with lead in Mason County like they have had in some other places. Part of it is because of our soils are glacial till. You don't have a lot of granite and decomposing. The minerals aren't they're just not here. So it'll be interesting to see if they tackle uranium, because 1/4 of the state has a problem with uranium in the drinking water, and that's not mentioned. It's very
And
interesting.
what are the long-term effects of that? Or short and or long-term effects of uranium?
Short term, not much. Long term, if they're drinking it. I mean, you can use it for showering and stuff, but if you're drinking it, it needs to be dealt with, because it can
And how does it present itself as a
high rates of cancer, like radon.
cancer?
It actually comes from the same mineral deposits as radon.
You glow.
And actually, there's a mine called the Starlight Mine outside of Chewela that does go out.
Really, I wanted to see it.
Yeah. We're going to go with the tobacco 21 is going to be a push, raising the age tobacco and vaping to 21. It didn't have a lot of traction last time. I don't know. With a longer session, it may gain some traction. Number 8, the rural water exempt wells is going to be an issue. They're going to try to tackle the Supreme Court decision in a legislative way.
You forgot 7, fish.
Oh, yeah, direct retail sale of fish. So a fisherman can come in and sell directly to a person on the dock. So in much the same way as a retail outlet.
And if I might add, the Washington State Department of Fish and Wildlife is trying to streamline their process. And that's why this is going back to the legislature.
Right.
So right now you can go onto the dock and buy from the
Yes.
fishermen.
Yes. But of all the people selling fish, only 6 have taken the time and effort to register with Fish and Wildlife. So they're trying to make it a little more useful law.
Right. Marijuana, we're trying to push that over to the Department of Agriculture to regulate the edibles. Opioids are in there, and that's, Dr. Hughes pushed that into the agenda for the state. Dr. Hughes is also on State Board of Health, so that's an ally we have there. And of course the budget. On the back page you have gun injury prevention, sugary drinks, and rapid health information data. So one of the things we don't have is the ability to access data in a quick way. Much of our data is 2 years out of date before we actually get it. So, and I'm actually working on the Governor's Commission on gun injury and suicide prevention. So.
Sure.
So,
And then the last couple things I have really quick. Oyster Fest went off without a hitch. We broke even. Between food permits and inspectors, it was a wash, that's the goal.
yes,
And nobody got sick, and everybody had a great time.
that's good.
And then we did renew our contract with Choice Network. So that's been renewed, signed off, paid, and I'm on the board of Choice.
Okay.
So, and that's all I have.
Okay. Any other board members have anything? How about the public? Any comments?
I just have a question about the notion of fee for service when you were talking about dollars that were going in, you had the comparison. You said, and we have a fee for service. Does that mean the clients pay fees,
Right, so, and that's
County pays
primarily in environmental health, so on-site septic, food
Okay.
permits, food handler cards.
Okay, okay. How does that, do you have comparison with other states on that?
No, because different states do it differently.
Okay.
You know, one of the things that we did do is we pushed the food handler cards to an online system. So they go online, take the test, get their card right then.
Okay.
And it's through Pierce County, a system we use there. Pierce gets to keep 3 of the $10, but we're actually up dollar-wise because we have so many more people getting their food handler cards, and it's so much more convenient. The manager at Walmart can just say, you know, all my employees will get their food handler card, boom, and they just go online and get it done. So, That's where we eventually hope to get to with online permitting for septic systems and fences and decks and everything else. So I think we'll get more compliance, voluntary compliance, and I think the revenue will actually go up.
It'll be a lot easier if they can just go online and do it.
Right, you can sit at home and do a roof permit or a fence permit,
Yeah.
and then save the time on a complicated system, a complicated septic system for the people at the front counter. I think it's a more efficient use of time.
Yeah, because if somebody can do that, instead of coming down here to do it, they might actually get the permit.
Mhm.
Instead of just do it. So, anything else? I guess we will adjourn then.
Okay,
Okay.
thank you so much.
Thanks.
Thanks,
And-
everybody.
And keep your emails open to know what day we're gonna be meeting again.
Is the meeting packet on the web?
Yes.